Good afternoon. Today we talk about RV function, PA pressures, and tricuspid regurg. It's a lot of material to cover in the hour, but we'll try to sort of do that. Why examine the RV? You know that the right ventricle is affected in many cardiac diseases. The scope of cardiac diseases varies from coronary artery disease, RV infarction, HFrEF, HFpEF, valvular heart disease, primary cardiomyopathic disorders, patients with a left ventricular assist device at various stages during their journey before, during, and after the device is implanted, heart transplant recipients, and so on. I can go on. There are data showing that RV function is an important predictor of what happens. Congenital heart disease is an entity by itself where the RV can play an important role in whether a patient has symptoms, has heart failure or not, and certainly a target for treatment. And many times we have cases in shock, hypotension, where the question is posed, what is the cause? And RV can be an important cause, for example, in the post-op setting. Okay, what are the views that we rely on? The first look we have at the RV is in the parasternal long axis view. That view gets you to see part of the anterior wall of the outflow tract. You see it at the top here. There are some thoughts that you can use this to get some measurements of wall thickness. As you can see, the resolution is not that great, that you are comfortable. I see the whole wall thickness. But in general, if the view is well oriented and it is not off axis or oblique, that's the first look you will have of the right ventricle. You can have a feel for how big that RV outflow tract is, or is it normal or not, and also how much that area changes. However, this view by itself is not the one that we use for making measurements, with the exception of sometimes, particularly in cases of arrhythmogenic cardiomyopathy, where you want measurements from several locations in the right ventricle, since the pathology can be patchy. You can go from the junction between the septum, see if I can use the mouse, and the aortic root to a perpendicular point, go up perpendicular to the corresponding point of the free wall of the infundibulum here, or the RV outflow tract, really. Sometimes if we see flow here by color Doppler reflecting flow in the chamber, and that's about what we get from that view. There is another view that you see, which is also a parasternal long axis view, that gets you more of the RV outflow tract, the pulmonic valve, and the pulmonary artery above the valve. And this is an ideal view to look at the infundibulum, to look at the pulmonic valve itself. Patients with infundibular stenosis, pulmonary valve pathology, you can align with flows also through the RV outflow tract in that view. We are all familiar, I suspect many of you have been through the lab, are familiar with the parasternal long axis view. And that view can sometimes get you the ostium of the inferior vena cava, and you can see the eustachian valve. You can also tilt and show the coronary sinus. But here we see from the RV perspective the anterior wall and the inferior wall, or the diaphragmatic wall, the wall of the right ventricle that sits on the diaphragm. As we will see, they have different arterial supply, and in patients with coronary artery disease, you may see segmental dysfunction. And of course, if there is a global reason for RV dysfunction, you will pick it on both of these walls. We also see the tricuspid valve leaflets. We see both papillary muscles. We see the chordal apparatus. We can interrogate the tricuspid valve with color. That's the view where you can get the vena contracta measurement for the tricuspid regurg, one of the views, not the only one. We'll talk more about that, and you can align with the tricuspid flow. The leaflets you get in that view are the anterior leaflet, and sometimes the septal or posterior leaflets here. How about the parasternal short axis view at the aortic? We can say that base of the heart that gets you the aortic valve, pulmonic valve, tricuspid valve. Again, another opportunity to look at the leaflets of the tricuspid valve. So here we have the anterior septal leaflets and the posterior leaflet here. We can also look at flow through the inflow portion of the right ventricle as well as through the outflow portion. We can look at the flow in the RV outflow tract and align with that flow. as well. Certainly an opportunity to look at the tricuspid regurg and try to align with the CW signal, using CW with the direction of the TR jet. There is a parasternal short axis view that is slightly tilted higher that would get you more of the pulmonary artery and its bifurcation. This is an important view if you're looking at patients with congenital heart disease who can have supravalvular pulmonary stenosis. And needless to say, your alignments here with Doppler will be a good one. Then we go for short axis views at the mitral valve level. And here you get to see the different walls of the right ventricle. So you'll see the anterior, the lateral, the inferior walls. You see the crescent shape of that right ventricle. In general, you can sort of have a feel of what the size of the RV is, what the function of the RV is, but not infrequently these are a bit off axis, so putting a lot of reliance on these and drawing conclusions about RV size and function is not the best strategy. You would appreciate, I hope, through what we've been talking so far, is you get to see the RV from multiple windows. That's the tomograms that we get, and at the end, whoever is reading the examination and whoever is scanning first should form an opinion, a final summary based on what they see, because we do not see the whole RV in any of the views. You've seen portions of the RV outflow tract, the infundibulum, and now we're looking at the inflow region from the four-chamber view. That's the view if you're going to do measurements, and these are encouraged for the basal part of the right ventricle, the mid portion of the right ventricle, and the long axis of the right ventricle. You can do these. That's also the view where you can look at atrial area, convert area to volumes. That's will also get dimensions for the right atrium, be it the minor dimension, which is septal to lateral, and long axis dimension superior to inferior. You align with TR. The challenge in the apical four-chamber view is that sometimes you do not see that lateral wall of the RV that clearly. And that's important because we want to sort of draw conclusions about RV function, and I want if I were going to do measurements, say for the area, I want to be comfortable that I am seeing the endocardium well. Sometimes you give ultrasound enhancing agents and that helps, but another important thing that is now part of the routine exam is for the sonographer, either with a medial or lateral rotation, trying to bring in the more of the RV free wall here, and that's the RV focused view. How do I get an RV focused view that shows the proper size of the right ventricle, so to speak, and not an under or an overestimation? The transducer should be sitting at the apex, and the left ventricle should be, left ventricular plane should be in the center of the cavity. If that is achieved, and gradual rotation is maintained, you will see the dimensions gradually increasing. And that's the view if you were to do just a basal measurement, which is the maximum dimension you get for the right ventricle, for the basal third, the one that you rely on. You can also look at the RA. You can see some of the interatrial septum in that view, try to align with TR, and so on. A modified four-chamber view that is focused on the RV can also be obtained, and sometimes you get a low parasternal position, and either intentional or unintentional, that's the only view I can get. And if you do so, you will do well in seeing the RV free wall. But the problem is this is not the view that we want to get measurements for the RV or the RA, because these are oblique views of axis views, and you will not get good measurements here. Needless to say, you can see the tricuspid regurg jet with color Doppler. You can try to align with it with continuous wave Doppler, so you get an estimation of the PA systolic. There is an apical five-chamber view with a focus on the RV. The advantage of that view is that brings the moderator band in the apical views. Nothing special about the moderator band till we come to talk about the blood supply in a short while. You can also get a coronary sinus view from that apical position, and the advantages is they get you different walls of the right ventricle. Here it's the anterolateral wall, and here it's the posterolateral or infralateral wall. Subcostal views are very important because in some patients these are the only windows you have or the best windows you have. And so we will be able to see the RV, the RA, again, more of appreciation of what they look like size-wise, but not really suitable for any measurements except for the thickness of the RV, as we will talk shortly. You can interrogate the interatrial septum with color. If there is a PFO or an ASD, you can align with it here, and you can get good alignment, and the signals you get can be later on be of value in gaining insight into left atrial pressure. Short axis views also from the subcostal position can get you the different valves. You can appreciate the pulmonic valve, and you can get very good alignments with the RVOT flow here. So these are the views that we rely on, and we want to be compulsive in pursuing them. Brief mention of the blood supply for the right ventricle. So as you all know, the main blood supply to the right ventricle comes from the right coronary artery, and the first branch that it gives is the acute marginal branch. The more the more proximal the lesion is, the more the damage to the RV, so to speak. The anterior wall of the RV gets its blood supply from that acute marginal branch, whereas the inferior wall gets its blood supply from the posterior descending branch of the coronary artery. So depending on the location of where the stenosis is or where the infarction has happened, you may see segmental dysfunction where one segment looks better than other segments. In that view that gets us, we talked about it from the parasternal position, more of a long axis of the pulmonary artery and the pulmonic valve. You can see the infundibulum. The infundibulum gets its blood supply from the conus artery. This is an artery that can come off the right coronary artery, but can also go through a separate ostium. Sometimes it's easier to get into that artery than to the right coronary artery itself, and sometimes when one gets in it, it can trigger arrhythmias. But that's what that artery does. How about the lateral wall of the right ventricle, be it anterolateral or infrolateral? This is usually, for the anterolateral, usually the blood supply comes from the acute marginal branch. For the posterolateral or inferolateral wall of the right ventricle, that greenish one, it would come from the posterior descending branch, but can also come from the posterolateral branch, and in 10% of the cases, these branches come from the circumflex. The apex of the heart and the apex of the right ventricle get their blood supply from the left anterior descending coronary artery. The posterior 1/3 of the interventricular septum gets its blood supply from the posterior descending coronary artery. All of that needs to sort of, one, be thinking of it if you're looking at a case with coronary artery disease and you're seeing problems, say, in the paralung, but not in the apical four or vice versa. These could be the reasons that explain them. We talked about the moderator band briefly. It gets its blood supply from the left anterior descending coronary artery, sometimes from one of its septal branches. And why is that important? Because if you're doing alcohol septal ablation cases, sometimes these septal perforators supply the moderator band, and you can see the moderator band lighting up. Okay. RV wall thickness. One of the responses of the right ventricle, typically to pressure overload, is hypertrophy of the right ventricle. So I want to measure the wall thickness for that reason. Which view do I rely on, or what is the view that is recommended really in the guidelines? It is the subcostal view. You want to sort of get your focus on that RV-free wall. You want to zoom on it, as you see here. And then you want to measure the wall thickness, as noted. The challenge is sometimes there is epicardial fat pad. Sometimes there are trabeculations. You want to exclude all of these. And also, if you sort of go along that free wall, you can appreciate that thickness varies from point to point. Sometimes not by much, but also the upper limits of normal is 5 millimeters. So give and take 1 or 2 millimeters can make a big difference in calling whether there is RV hypertrophy or not. So ideally, the level at which this is measured is at the tip of the anterior leaflet of the tricuspid valve and end diastole. Now let's talk quickly about the dimensions. We said we can get from the apical 4 dimensions for the right ventricle, what we call minor dimensions, to distinguish them from the long axis, major dimension, at the basal third, at the mid third of the ventricle. The basal one, the upper limits of normal is 41 millimeters, and you can get that from apical form, but also reliably from the focused view. The RV focused view is also the view that we rely on in trying to get 3D images, as we will talk, so that's why this is a critical part of the exam. And you would also get good RV free wall strain from that view. So missing an RV focused view is a big deal. The second minor dimension is sort of, you can say, halfway down that ventricle, said to be at the level of the pap muscles for the left ventricle, and the upper limits of normal is 35 millimeters. And then the lung axis is from the tricuspid annular plane to the apex, and the upper limits of normal is 83 millimeters. Notice that I talked about absolute measurements. I did not index or refer to the index dimensions per body surface area. Unlike many other things that we do say for the left ventricle, be it dimensions or volumes, and even volumes for the RV and atrial volumes also, both left atrium and right atrium. Part of the reason these were sort of presented this way is the original studies from which the normal values were obtained did not index them. So my take-home message is, yes, I want to know the measurements, but I also want to put them in perspective. Example, the RV is normally not more than 2/3 the size of the LV. So if you're looking at a heart where the RV is the same size as the LV, or now larger than the RV, but I'm getting a measurement that says 39 millimeters, I will call that enlarged. For that individual, this is an enlarged. How much enlarged? The most accurate conclusion would arrive with 3D volumes. Fractional area change, we may be familiar with its concept with respect to the LVEF, say, but here, unlike the LV, we are not looking at all the RV for the fractional area change. It's just that in flow, we are ignoring what is happening for the RV outflow tract. And basically, we are looking at the end diastolic area and the end systolic area. The difference between them divided by the end diastolic area is the fractional area change, and you see different examples here from something normal, low normal, and clearly reduced. The lower limits of normal is at 35%, and that's a number you should memorize. How do we get the end diastolic area? We start here at the lateral edge of the tricuspid. You track all the way along the free wall, which means I should see the free wall well to the apex, and then along the septum to the septal side of the tricuspid annular plane. The upper limits for the end diastolic area, which is an indicator of the RV size, for men is 12.6 centimeter per meter squared. For women, it's 11.5. For the end systolic, the upper limits for men is 7.4 centimeter squared per meter squared. For women, it is 6.4. Has there been any validation for this fractional area changes and index of RV systolic function? Yes, there are validation studies that showed its correlation with CMR, 3D, also echo 3D EF with decent correlations. Having said that, there is always some degree of spread, perhaps related to the quality of the images and to what extent the pathology is focused on that inflow portion or also the outflow, which we are not accounting for. Other tools that are in the guidelines, one of them is actually recommended, the TE index or the myocardial performance index. The first one we'll touch bases on quickly is the first differential of pressure. So DPDT, and similar to the LV, or if you have a catheter in the RV, a rapid rise in pressure is an indicator of a better RV contractility. By itself, even if you were to do it by cath, this is not a pure index of contractility. It is also affected by loading conditions. Having said that, the concept is similar to what we do with the mitral regurg. You look at 2 points in time, and you look at how much pressure changes between these 2 points. So delta P divided by the time interval it takes, and that will get you the millimeter mercury per second. The 2 points recommended are a velocity of 1 meter per second. The second point is 2 meters per second. And so if you work the math, it's 12 divided by the time interval you get here. There were some studies that said you do better in terms of accuracy or maybe more reproducibility as opposed to accuracy, if you start for a 0.5 meter per second as your starting point against a 2 meter per second as the other pressure point or the velocity point that you will convert to pressure. Having said that, this is not a metric that sort of is recommended, but the way I would say you want to use it is look at the slope. If you see it's something rising fast, steep, this is usually a better function. Something that is rising very slowly, then that's a worse RV systolic function. The magic number, the cutoff that is defining an abnormal value is less than 400 millimeter mercury per second. The myocardial performance index is an index that says the longer the time the heart spends not ejecting blood, the worse the function of that heart. And so we try to look for the isovolumic contraction time and isovolumic relaxation time, their sum in the numerator divided by the ejection time in the denominator. And the higher the ratio, meaning more time spent not ejecting, the worse the performance. How do we do it on the left side, on the right side? You need at least 2 cardiac cycles, and you need views, you need Doppler signals from different views. Why I say that? As you see here, if we look at the time interval between the end of the tricuspid A wave and the onset of the mitral E wave in the second cardiac cycle, that time interval encompasses the isovolumic contraction, the ejection, and the isovolumic relaxation time. But I cannot get ejection time from the tricuspid inflow position. So here I have to go to the RV outflow tract and get the ejection time from the RV outflow tract signal. So I have to look for RR intervals to be matching, otherwise I'm throwing in another variable. Another approach is if you have a tricuspid regurgitation signal, remember, you can use it. So how do I do that? Tricuspid regurg occurs during isovolumic contraction, ejection, and relaxation. So now I have that, all that time interval from the TR. But I will still need the ejection time from the RV outflow tract. So the total duration of the tricuspid regurg minus the ejection time gives me the numerator. At its face value, it's sort of an interesting concept. The problem with it is if we submit to the proposal that the higher the ratio, the worse the function, there will be situations where the function is not good, but the ratio is not that much elevated. Example, whether it's left-sided or right-sided, the isovolumic relaxation time depends on the atrial pressure. If the atrial pressure goes up, that isovolumic relaxation time becomes shorter. So now I have a diseased heart with diastolic dysfunction, short isovolumic relaxation time, meaning a smaller numerator, and therefore a lower myocardial performance index. This index on the right side has been looked at in patients with heart failure, has been looked at in patients with cardiac amyloidosis, and is associated with outcome. Having said that, we do not typically rely much on it. We rely more on other indices. One of them we already talked about, the fractional area change. What's the upper limit of normal if you use the pulse wave Doppler method that we just talked about? The upper limit is 0.43. Another thing that can spare you the multiple cycles that you have to deal with is to look at the tricuspid tissue Doppler signal. And here we have the systolic ejection signal. We have an isovolumic relaxation velocity, early diastolic and late diastolic velocity. And so now it's easy. I can get all my time intervals from here. Having said that, the challenge with that is it's 1 point, meaning just that lateral side of the tricuspid valve. Is this reflecting what is happening throughout the ventricle? The second thing, the normal values are not interchangeable. The upper limits of normal by this method is a 0.54, whereas here is a 0.43. Of course, machines can do that automatically, and they can present you with all these values so you do not have to sort of struggle and go after them. What is recommended in the guidelines and what has been used in clinical research is the tricuspid annular plane, systolic excursion, or TAPSE, which you can get with M-mode as you see here. TAPSE is an easy signal to acquire and to measure. However, it has its limitations. One, it is at the level of the tricuspid annulus. It doesn't tell us what is happening through the rest, albeit reflective of the lung axis function. It is also affected by the translation motion of the heart. In general, TAPSE is more of a specific as opposed to a sensitive finding of RV dysfunction. The lower limits of normal is 17 millimeters. Similar to the TAPSE is, instead of me looking at the displacement, now I am going to measure the velocity of how much that tricuspid annulus will move towards the apex from an apical transducer position. So you have that systolic velocity. There are actually two small velocities. One is isovolumic contraction, which you do not want, but you want the systolic ejection velocity. You can do it by pulse wave Doppler or by color-coded tissue Doppler that fell out of favor or recommendation. The lower limits of normal is 9.5 centimeters per second. Again, it's a segmental velocity, not a global index in its true value. It's affected by the angle between the ultrasound beam and the plane of motion, so has the potential of being falsely or spuriously reduced if the alignment is not a good alignment. Again, for both TAPSE and S prime, there are some validation studies showing significant correlations, be it in the range of 0.4, 0.5, with radionuclide angiography for RVEF, and some with CMR, and some with 2D RV function EF, albeit that is not accurate and not really recommended, that 2D approach for RVEF. This takes us to strain. Strain is looking at deformation that is happening, how much compression happens. Strain is an index of contractility, but is also affected by loading conditions, both preload and afterload. The advantage of strain is when a segment, say you have a dysfunctional segment and you have a normal segment, the normal segment can pull on the dysfunctional segment, making the dysfunctional segment move and give the impression that that dysfunctional segment is performing when it is not. Strain will take care of that issue. It has been validated against sonomicrometry, against strain obtained by sonomicrometry in animal studies, and you see here one of the good correlations. At first it was obtained by tissue Doppler, which is a bit more noisy, but has a very high temporal resolution, needs really high frame rates of like 150 frames per second. Now we rely on speckle tracking, and it is easily done. And you can do segmental strain for each of the basal, med, and apical segments, or you can do strain for the whole RV or just the RV free wall. Since the septum is shared by both the RV and the LV, the interest is more in the RV free wall, with the understanding that this is where you get more of a purer metric of RV function. The magic number here is at 20%, so a value of 23, 24, 25 is good, for example, normal, but less than 20% is, if we ignore the absolute sign, 18, 17, 16 is a depressed RV function. There are data showing that in carriers for arrhythmogenic cardiomyopathy, you can have these low 20s range for the RV free wall strain, and that may detect early disease in some populations. RV volumes and with 3D, the 3D has the advantage of getting you all of the right ventricles. So you have the inflow region, you have the apex, you have the RV outflow tract, and here we get a true RV volumes measurement, and we can get an ejection fraction. These have been validated against CMR. Correlations better for EF than volumes. Despite using 3D, there is still underestimation. In general, when we scan and we look for 3D, we want to keep the frame rate on the higher side, which means I have to pay attention to the depth and the sector width, and I would aim for at least 20, 25 volumes per second. Before we leave the 3D, just to give you quick numbers, and again, I'll show them at the end, but these are numbers that you should sort of memorize and become familiar with. The upper limits of normal RV and diastolic volume index for men is 87 ml per meter squared. For women, it's 74. For end systolic volumes, it's 44 and 36 respectively. For EF, the lower limits for 3D RVEF is 45%. Atria. Unlike the left atrium, we have two planes to deal with the left atrium. The right atrium is that apical four-chamber view, and we rely on it. The upper limits of normal for men, and of course the maximum volume for the atrium is end systole before the tricuspid valve opens, is 39 ml per meter squared, for women 33. If you're just doing area, the upper limits of normal is 18 centimeters squared. Dimensions are not recommended, though the upper limits of normal for the septal to lateral is 4.4 centimeters, and for superior to inferior is 5.3. So let us move now to the pulmonary hypertension evaluation. As you know, the right ventricle is affected in pulmonary hypertension, and we get patients with pulmonary hypertension referred for an echocardiogram. What's the definition of pulmonary hypertension? It is defined by the mean PA pressure, not by the PA systolic pressure. At first, it was a 25 millimeters mercury. The most recent WHO statement refers to 20 millimeters mercury as the upper limits of normal. So if I want to do a really good job in my report, I should aim to go after the mean PA pressure as opposed to just PA systolic. So we'll show you how we go about that. There are a group of patients, what we can say group 1 pulmonary hypertension, where the mean pressure is up. We can replace that 25 with a 20, but where the wedge pressure, and preferably the end diastolic pressure, not just the wedge pressure, is at most 15 millimeters mercury plus increased Wood units. The normal pulmonary vascular resistance is less than 1.5. More than 3 Wood units is in the pulmonary hypertension category. So can I estimate PA systolic, PA diastolic, and therefore the mean? Obviously, if you know the systolic and diastolic reliably, this mean could also be mathematically obtained, not a challenge. But also another goal is, when I look at a case of pulmonary hypertension, would I be able to give clues to the referring physician? This may be group 2 pulmonary hypertension as opposed to a non-cardiac etiology. And then RV function and RA volume. These are predictors of outcome in this patient population, even the non-cardiac pulmonary hypertension. So TR-JET, and as you've seen from the early slides, we kept talking about TR. I want to get multiple windows to get to the TR-JET. That is important. And also we can use intravenous saline, or if you're giving ultrasound enhancing agents for good endocardial border definition, you want to go back and get the TR-JET. Subcostal views are needed for the estimation of right atrial pressure. We'll talk some about that. We talked about the saline. If somebody has pulmonary hypertension, it is highly feasible to get TR, well in excess of 90%. Also, when you look at the PA pressures, it should fit with everything else. Example, we know that in patients with a good degree of pulmonary hypertension, good degree like, say, a mean PA pressure of 50 millimeters mercury, you will see a D-shaped septum. So if you see a D-shaped septum and it's a proper cut, nothing off axis or oblique, and you have a TR of, say, 3, you have to question whether that TR is all that there is, or there is a higher velocity from elsewhere. That's an incomplete jet you do not want to use, and that's a jet that you can enhance, and then we apply the modified Bernoulli equation with the RV-RA pressure gradient plus the right atrial pressure. In this example, without me adding any right atrial pressure, I know that the RV systolic is at least 52. I'm saying RV systolic and I'm showing PA systolic. Are they the same? If there is no stenosis, be it infundibular or valvular, the RV systolic pressure should be the same as the PA systolic pressure. But if you're looking at cases with congenital heart disease, patients with prosthetic pulmonic valves, be aware that the RV systolic can be different from the PA systolic. How about PA diastolic? Here we rely on pulmonary regurgitation by continuous wave Doppler, and you can get it in the short axis view. I will submit that its feasibility is not as high as the TR-JET. Again, we need an estimate for right atrial pressure to combine with the PR-JET. If you use saline, that can sometimes enhance it, as well as ultrasound enhancing agent. Feasibility in patients with pulmonary hypertension is more than 70%. The velocity we are interested in for PA diastolic is the end diastolic velocity, that one. So if we look at the modified Bernoulli equation here, the PA diastolic minus the right atrial pressure, assuming the right atrial pressure is the same as the pressure in the ventricle at end diastole when that velocity is recorded, you can see a gradient of 16 millimeters mercury, and all you have to do to that is add the RAP. I will also tell you that estimation of PA diastolic pressure in the absence of pulmonary disease can be very valuable to gain insight into what the left atrial pressure may be. So now we talked about PA systolic, PA diastolic. How about the mean? The first method to get to the mean pressure is to say I have the PA diastolic, I have the PA systolic, so the mean is diastolic plus 1/3 pulse pressure. Done. As you can see, this depends on at least three measurements: the peak TR velocity, the end diastolic pulmonary regurg velocity, and my estimate of right atrial pressure. If each one comes with its errors, this can be erroneous in some cases. Another approach is to look at the peak velocity of pulmonary regurgitation, that signal, and then do the 4V squared plus an addition of right atrial pressure. There are some publications that have done it without RAP, and there are others that have done it with right atrial pressure. The guidelines from 2010 from ASE do recommend adding the RAP here. Another approach that has been published, I will say, at first abstract forms, but more recently there was a lot of manuscripts looking at that acceleration time, how fast the velocity in the RV outflow tract increases. If it takes a short time for the velocity to increase from 0 to its peak value, that's a short acceleration time, and that is seen in situations with pulmonary hypertension. And that's the regression equation. So you put the acceleration time and you use that equation to come up with the mean PA pressure. In general, if you have a case of pulmonary hypertension, the acceleration time is at most 100 milliseconds. There are, however, other studies where a different regression equation is recommended based on what cutoff values you are anticipating in terms of PA systolic pressure. Is there another approach for mean PA pressure? Yes. You can look at the systolic gradient between the right ventricle and right atrium from the tricuspid regurg jet, so you get a mean gradient. And the idea is somebody who has a higher systolic pressure will also have a higher mean pressure. Just mathematically, they are related. And for that reason, then, whether we use the mean gradient or we use the actual pressure value in a regression equation, you can get mean PA pressures. These have not, that last particular equation has not been used a lot, though you may see more of it in research studies. So that's the peak velocity that we were talking about, the easiest one to do, and it is the 4V squared. And here, without adding any RAP, you can see there is a significant degree of pulmonary hypertension with a very high mean pressure. To get a handle of pulmonary hypertension, as you saw in the definition, it is not just pressure. There is also the component of pulmonary vascular resistance. So I have to account for flow. Example, young individuals, young male athletes have been shown to be capable during exercise to get to PA systolic pressures in the high 50s, low 60s millimeters mercury range. They are doing this not because their pulmonary vascular resistance is up or is compromised. They are doing it because the stroke volume increased. And so Dr. Schiller and his group introduced this concept of saying, let's get a PA pressure estimate and let's get a cardiac output estimate, and the ratio between them should give us an idea about the pulmonary vascular resistance. Before I go in, you can readily appreciate that the peak TR velocity is not the same as the mean PA pressure. Also, the pulmonary vascular resistance expression needs a measurement of left atrial pressure or mean wedge pressure. That expression ignores it. Likewise, in the denominator, we have the time velocity integral of the RV outflow tract, but that's not the same as the flow. We need the diameter. Why did the investigators go after these? So as to simplify the method. Turns out if you have a ratio more than 0.38, this is very specific, but notice the value of the pulmonary vascular resistance, very high value, more than 8 Wood units. A ratio 0.12 to 0.15, these are individuals with normal pulmonary vascular resistance. In between the 0.15 and 0.38, that's where there is a challenge for that approach by itself. Having said that, irrespective of the accuracy, if I'm generating this value, say, for a given patient, and it's high, that is not a good predictor. It's not a good predictor of something good. It's a predictor of something bad going to happen to them, and that was sort of shown in a large study with 795 patients with CAD, again from Dr. Schiller's group. So we talked about PA pressures. Let's talk about RAP. The first thing we rely on the RAP is the inferior vena cava. We are taking somebody who is capable of breathing spontaneously, who will follow commands, who will do their best. We're not talking mechanical ventilation now. The idea is as the RAP goes up, the IVC diameter goes up, and the collapse of the IVC with inspiration becomes less. If somebody takes a deep breath in, the right ventricle, so to speak, sucks the blood, the right atrium sucks the blood from the vena cava, and these collapse. But if the pressure is high, even though there is this effort of trying to get blood out of the vena cava, they will remain dilated. And you see an example from a normal subject here and from someone with very dilated IVC that doesn't change at all, and also you can appreciate that the hepatic veins are dilated. By the way, dilated hepatic veins have also been associated with high RAP. That's one of the studies back in '96 showing the correlation between the IVC collapse index and mean right atrial pressure. As the collapse index is higher, more collapse of the IVC, the lower the right atrial pressure. The solid circles show the performance in patients who are not on mechanical ventilation, and the performance is good. However, if you look at the open circles, that's the performance for patients on mechanical ventilation, and here the collapse index and the size of the IVC are not good metrics of right atrial pressure, meaning somebody could have a normal right atrial pressure, they are on a mechanical ventilator, and the IVC is dilated when the RAP, as I just mentioned, is normal. However, if you see an IVC that is at most 12 millimeters in diameter, their RAP, even if they are on mechanical ventilator, is usually less than 10 millimeters mercury. The magic cutoff value for what defines a dilated IVC for someone not on mechanical ventilation is 2.1 centimeters. Endurance athletes can have a dilated IVC and their RAP can be normal still, and that's one of the limitations. So we talked about patients who are in respiratory distress who won't be able to cooperate with you. So unless the IVC collapses on its own and they're not able to do a good sniff effort, that will be a problem for us. Patients on mechanical ventilation, we already touched on that point. And if you have somebody post-op, no subcostal views. Hepatic vein flow and mitral inflow similar to tricuspid inflow and hepatic vein flow similar to mitral inflow and pulmonary veins. You look at the E to A ratio. Again, in normal individuals, you can have a high ratio and their RAP is normal. In diseased hearts, the higher the ratio, the higher the right atrial pressure. For hepatic veins, you look at flow during systole and diastole. The more flow you see in diastole in patients with diseased hearts, the higher the right atrial pressure. In young individuals who are healthy, you may see predominant diastolic flow in the presence of a normal right atrial pressure. That's why clinical context matters when we try to interpret these signals. You can have a ratio less than 0.8 or more than 2.1 in diseased hearts. They have been used as impaired relaxation and restrictive, and in between as pseudo-normal, where you rely on other things. That shows you a correlation in 35 patients, some on mechanical ventilation, between the E to A ratio and the mean RAP. Again, some degree of scatter, as we talked about. Hepatic veins, predominant flow in systole, usually normal. RAP, systole equals diastole, usually in the 5 to 10 millimeters mercury range. Predominant diastolic, though, is an increased RAP, and that's the ratio of the systolic time velocity integral, or velocity, divided by the sum of both systolic and diastolic, and that's the inverse relation. The magic cutoff value is 55% for that systolic filling fraction. Another interesting signal you get from the hepatic veins is that atrial reversal. That's the P wave. You see that very high atrial reversal signal. You see it high in absolute value. It's clearly, say, 80 centimeters per second or so, and long duration. Similar to the A reversal in the pulmonary veins, that tells you that RV diastolic pressures, late diastolic pressures, are elevated. Systolic reversal in the hepatic veins, seen with significant degree of tricuspid regurg, usually in the setting of increased RA stiffness. What are the limitations for the hepatic veins? Pericardial compression syndromes, tricuspid valve disease, arrhythmias with AV block, tachycardia, heart transplant recipients, and again, absent of subcostal views that led to the looking at other indices, and other indices are back to tissue Doppler velocities. The first one is that time interval between the end of the systolic ejection velocity and the onset of E prime. That time interval, the shorter it is, the higher the pressure. You can call it isovolumic relaxation time by tissue Doppler, and also the E to E prime ratio. What's the lower cutoff value for an E prime on the right side? It depends with age. The guidelines recognize a value of 7.8 centimeters per second as the lower limits of normal. And this is the tricuspid E with the tricuspid E prime, EA here for annular, and the cutoff value is 6. Though in ventricles with normal RV, normal hearts, a ratio of 4 is more predictive of elevated pressures. That's one of the earlier publications from here showing the association of the ratio with mean RAP. That's a study from Japan taking patients with pulmonary hypertension. You see a decent correlation, R squared of a 0.64, so an R of about 0.8 here. And you see the cutoff value of 6.8 being associated with worse outcome. Limitations occur in patients with pericardial compression syndromes, tricuspid valve disease that influences both tricuspid E and E prime, arrhythmias, and of course if you do not have apical views. That's a rough guide of how you can estimate the the mean right atrial pressure. One way of doing things easily is if I see the IVC normal size collapsing, I'm done 0 to 5. If I see it dilated more than 2.1, not collapsing at all, that's more than 20. In between, then I'll go to the hepatic veins, and depending on what I see in the hepatic veins, I can downgrade or upgrade. Examples from a dilated RV here with a big RA. By the way, as the RV pressures go up in diastole, the right atrial volume also goes up and the right atrial area increases. So a dilated right atrium is a finding that is seen with high right atrial pressure. Caveat, there are other reasons that can cause a dilated RA. Another interesting thing to pay attention to is the interatrial septum. As the RA pressure goes up, the septum will move from the right to left direction. And a septum that keeps looking to the left atrium throughout the cardiac cycle is an indicator that the RA pressure here is higher than the LA throughout the cardiac cycle. TR, PR, hepatic veins, and here we can get all the components, PA systolic, diastolic, mean, and RAP. 4-chamber views, while we attempt them, I put this one because it shows that you can have problems with angulation in terms of trying to get mitral inflow and lateral tissue Doppler velocities in patients with a good degree of pulmonary hypertension. We talked about the D-shaped septum. Systolic overload, you will see the D-shaped septum both systole and diastole. Volume overload diastolic. And it reflects the RV-LV pressure gradient. We talked that one of the goals is to say whether this pulmonary hypertension is of a cardiac etiology or not. So that's an example from a patient with primary pulmonary hypertension, group 1, pulmonary hypertension. You look at the mitral inflow, it's really low velocities and E less than A. You look at the septal annulus velocities, they are reduced, but the E prime on the lateral side is preserved. That tells us that the LAP here is normal or even reduced. Unlike this patient who has a group 2 pulmonary hypertension, notice the ratio here is more than 1. Both velocities, septal and lateral, are reduced. This is a study from our group years ago showing that the interrupted line and the open circles showing the correlation of lateral E to E prime with the mean wedge pressure in patients with group 2 pulmonary hypertension as opposed to group 1 pulmonary hypertension. You see all the points here clustering with an E to E prime ratio that is hovering around the 5 as opposed to values 15 and above. So that's the table, and it will be available. If you're going through studying, knowing more about it, these are numbers that it is expected that you would know. I covered a lot of them during the presentation and we'll move on. Tricuspid regurg. In the last few minutes, what do we need to do for tricuspid valve assessment? One easy thing to do is think of the mitral side, and everything that you say on the mitral applies to the tricuspid in concept. So if you have a significant degree of tricuspid regurg, primary tricuspid regurg for now, we're not talking secondary, you will see an RV that is enlarged and that has a normal function. So if you're looking at an echocardiogram and you have a big RV that has a normal function, one of the reasons or one of the things you should ask yourself, what is the tricuspid regurg like? Significant tricuspid regurg will lead to a large right atrium. So to have severe TR, unless this is acute, the RA should be enlarged. If it is not, something is not flowing right. Then you want to look at the tricuspid valve apparatus itself, and we talked about the annulus, we talked about the PAPS, chordal apparatus, etc. There are some things that can be accomplished by transthoracic, some things by transesophageal, and some things that CMR can do as well. Usually with a significant degree of tricuspid regurg that has been present for some time, you will see an IVC that is dilated and RAP that is up, and so you will not see that great collapse. Tricuspid inflow, similar to the mitral inflow, tricuspid E velocity by pulse wave Doppler will be increased. The magic number is about 1. Though flows on the right side vary with the respiratory and cardiac cycles, so you want to average at least 5 or get end expiratory values. Hepatic venous flow, we saw the systolic reversals. Why do I need PA pressures? To help in part for the differential. If it's a primary TR disease, these PA pressures are not usually elevated. The other point to bring about the PA pressures is there are situations where the TR is so wide open that it is not reliable to apply the modified Bernoulli equations to estimate PA systolic pressures. These are different looks by 3D showing you the anterior, posterior, and septal leaflets of the tricuspid valve. And that's an example. Let's see if it will play. By TEE, albeit, showing you the RA big, the RV dilated, and you can see that the leaflets are not coapting. The upper limits of what defines a dilated tricuspid annulus is a 40 millimeter or 21 millimeter per meter squared. The 3D is very nice. You can appreciate that there is a gap here through which the leak must be happening. We look at color Doppler, and we can do proximal flow convergence. You can do that from the RV inflow, paralong. You can also do it from the apical 4. If you set the Nyquist at 30 to 40 centimeters per second, this is taken from the guidelines. A radius less than 0.5 is seen in mild TR, more than 0.9 in severe TR, and in between points is in the moderate TR range. If I do not want to do calculations, the vena contracta again, and you have 2 chances to get the vena contracta, but to get a good vena contracta, you want to see the whole jet, and you want to zoom. You can get that from the tricuspid inflow, from our parasternal RV inflow view, and you can get it from the 4-chamber view. A vena contracta less than 0.3 mild, 0.7 or above severe, and in between moderate. Jet area, and the jet area is problematic for eccentric jets, not for central jets. For the same amount of leak, an eccentric jet that hugs the wall will look smaller in area than a central jet. Less than 5 is mild, more than 10 centimeters squared is significant, and in between is moderate. You can also index the jet area to the size of the RA, so you planimeter the area. If you're going to do 3D vena contracta, this is the number that's in the guidelines, 0.4 centimeters squared. Not very clear about its feasibility in terms of what is published in the literature, nor its accuracy, though there is interest in adopting it. You must be familiar by now with the proximal flow convergence and the expressions that we use, and that's the expression that we use. If you do that, you can calculate the effective regurgitant orifice area. Less than 0.2 is mild, 0.4 or above is severe. Corresponding values for regurgitant volume is 30 and 45. Unlike the mitral regurg situation, you can appreciate that 15 cc's easily within the reproducibility of the measure can throw you from mild to severe or vice versa. So I'm bringing this up to say we want to sort of look at many things. It is not just numbers, because numbers have their limitations. That's an actual example of how the ERO and the regurgitant volume is calculated. So we have a radius of 0.9, an aliasing velocity of 32, and a peak velocity by continuous wave Doppler of 386. You plug it, that's a large ERO, and if you multiply that by the time velocity integral of the tricuspid regurg, you have the severe TR situation. Over the years, people have recognized that it is not infrequent to underestimate the actual regurgitant volume of tricuspid regurg just by that approach. And so there is a ratio that was introduced by Dr. Thomas and his group first that looked at a correction factor, so to speak, such that the tricuspid regurg volume that you calculate by PISA ends up being similar to what you would get if you were to do volumetric flow across the tricuspid valve, and you subtract from that flow through the RV outflow tract. Not in the guidelines, though it is brought up. We looked at its application, as you will see, and it didn't really sort of make a huge difference. One message I want to get across: many people think of the peak velocity of the TR as equal to severe TR. This is very wrong. There is no direct relation. In fact, some of the most severe TR cases can have a very low velocity. So be careful. And you can have very mild TR with very high velocities in patients who say pulmonary hypertension. That's an example of a mild and a severe TR. Continuous wave Doppler, things that tell us that the TR is severe is the brightness of the signal. Here is very comparable to that of the inflow. It means the same red blood cells reflecting that TR, and you also see that it's early peaking or more of a triangular thing with rapid cessation of flow once you get to that peak. Why? The RAV pressure rises very fast from that flow of the TR. We talked about hepatic vein flow and systolic reversal, similar to the concept of systolic reversal in the pulmonary veins. Whether you get systolic reversal or not depends, yes, on the tricuspid regurg volume, but also depends on RA pressure and stiffness, depends on RV systolic properties, depends on the pressure in the right atrium, the phase of respiration as well. This is taken from the 2017 guidelines, and basically the approach that is recommended is you say, am I dealing with a mild or a severe? And you look for a bunch of findings. It is not a hierarchical approach, meaning they do not say do this and then do that. They are saying these are a bunch of things that you look at together and then weigh it. Either you put a patient at severe or you put a patient of mild. You can say that the beauty of this approach in terms of not relying much on quantitation, you only go to the quantification piece, measuring vena contracta, ERO, regurgitant volume if you're having conflicting signals or something that puts you in the middle. We did a study a couple of years ago, 3 years ago, with Dr. Yang and Dr. Shah, where we looked at CMR to quantify tricuspid regurg volume, which is a solid tool to quantify that, and compared it with different echo measurements. And what we've noticed is that a large right ventricle in the setting of a normal RV performance is very specific, albeit not very sensitive. Jet area was also specific, but again, not sensitive. You can understand that because of the eccentric jet. Systolic reversal, pretty specific. A dilated IVC with a large vena contracta, but lower sensitivities. One of the very useful features was the continuous wave Doppler. The triangular contour had the highest specificity at 96%. But again, when you look at them collectively, because of the sensitivity, the performance for each signal is not great by itself. We thought things that can become easier if you take a hierarchical approach. So we look at some things at a time, and because of the high specificity of that triangular CW signal, we said this could be the starting point, and if not present, then go down the right of RV size, systolic reversal, and if it is present, then just look to confirm TR is severe by one more signal, and if that is the case, then we put the patient in severe TR. So we'll look at one case that's a transplant with fatigue. You can appreciate the TR. You see the rounded septum during systole, somewhat flattish during diastole. You appreciate the big RV. The leaflets, the annulus is dilated, leaflets not coapting. If you look at the color and you ignore many other things that you've seen, you may overpass this. And look at the IVC and the hepatic veins, and look at the systolic reversal. Thank you.